Good afternoon, everyone, and welcome to the second webinar of our four-part series on dementia across the spectrum, hosted by the Office of Lifelong Learning and the Physician Learning Program at the University of Alberta. My name is Rose Young, and I'm an associate professor for the Division of Endocrinology and Metabolism and a senior medical director at the Office of Lifelong Learning Physician Learning Program. We are committed to providing reliable updates, resources for clinicians, healthcare professionals, and everyone committed to providing the best clinical care for patients. We would like to start by welcoming everyone today as we acknowledge the University of Alberta. Its buildings, labs, and research stations are primarily located on the territory of the Nehiyaw, the Niitsitapi, Métis, Nakota, Dene, Haudenosaunee, Anishinaabe, lands that are now known as part of Treaty 6, 7, and 8, and the homeland of the Métis. The University of Alberta respects the sovereignty, lands, histories, languages, knowledge systems, and cultures of all First Nations, Métis, and Inuit nations. Some housekeeping info I would like to start with. Please use the chat feature if you have a question about technical difficulties or L3PLP programs and services. And if you have a question for the speaker, please use the Q&A feature next to the chat button. This function allows you to review what has been asked, and you can upvote those questions you would like answered. We cannot guarantee that the panelists will be able to respond to all your questions today. A recording of the webinar will be sent via email to all those registered. Participants can claim CME credits and complete a personal development activity using My L3 Plan tool. For more info, visit the QR code. This activity has not been formally reviewed by the CFPC or the Royal College. However, it is eligible for non-certified credit. MainPro Plus participants may also earn additional certified credits by completing a linking learning exercise. So today we are very pleased to welcome Dr. Diana Rucker and Dr. Lesley Charles, who will be talking about driving assessment and moderate to severe dementia. Dr. Diana Rucker is a clinical associate professor at the Department of Medicine here at the U of A. She completed her medical degree at the University of Calgary, and she subsequently completed training in internal medicine and a fellowship in general internal medicine here at the U of A, followed by a fellowship in geriatric medicine at Harvard. Her academic interests focus on decision-making capacity, particularly its impact on hospitalization and cognitive outcomes among socially vulnerable populations, including individuals experiencing houselessness. Dr. Lesley Charles is a professor in the Department of Family Medicine here at the U of A and the Care of the Elderly Program Director. She received her medical degree from the University of Edinburgh, a diploma in the care of the elderly from the University of Alberta, and certificate of added competency from the CFPC. Dr. Charles has published extensively on decision-making capacity, care of the elderly program competency, and training caregivers. Thank you so much for being here to share your knowledge and expertise.
Oops, I just having a little, is it up now or am I?
No, you're not sharing yet.
Okay, sorry. Sheesh. I have share. Is it okay now? Okay, sorry about that, guys. I'm a little bit of a techno Luddite.
You just have to press your presentation button.
Yes, there we go. Is that good? Okay. And then I'm just going to okay, so today we're going to have cover the topics of driving sensation, as well as how do we handle moderate to severe or end stage dementia, and that includes the behavior and psychological symptoms of dementia. that we often call BPSD. I have a very small disclosure from Eastside being on their advisory board, and Lesley is a speaker and has honoraria from the University of Calgary as well as the Eastside Advisory Board. And today we're part 2 of 4, and I already explained that we'll do driving and moderate to severe dementia. And I did want to have a very quick slide on following up on lecanemab from last week. So as a group, we're literally ironing out the final kinks, and we are going to treat people who want to try lecanemab, which is the monoclonal antibody. And just to remind you, it's not covered by Alberta Blue Cross right now. But even the situation is a little bit fluid. And as we speak, already there's 2 insurance policies that will cover some of the drug. So if you have patients that are really interested, you can refer them just to our clinic. The link is on the bottom there. I didn't want to say it, but if they are appropriate, and I hope that you can limit it to people who are appropriate, like the MCI, no more than 2 IADL impairment. You didn't hear it from me, but if you put semi-urgent or urgent in the referral, we'll try to see them in a timely fashion. And just some of the inclusion criteria, as they're not on a DOAC, they can go in an MRI scanner, and they have a support person. So today's outline, we'll start with Lesley, and then I'll start with the moderate to severe dementia after that. Lesley, do you want to jump in?
Can do. Okay. So we have a case here. Lady living alone. She's independent with her basic activities of daily living. However, in terms of the instrumental, those most complex ones, the daughter is managing the finances, and she's beginning to be concerned about her driving. She recently got lost on a route that's very routine for her. She has a MOGA of 21. What else would you like to know? What would you now do? And you can take the poll here. Would you at this point take her license away, refer her to Drive Able, refer her to Driver Fitness, who can organize, or at least recommend an on-road test? All of the above, or your last option is to send her to geriatrics to be assessed. Okay, so most of you are going to send to geriatrics, which is good. We're always happy to see these patients and to be the bad guy when the license needs to be taken away. So let's go through what to do when assessing a patient for driving, just in case you know what you are experiencing that long wait list for geriatrics and you need to do something sooner. Next slide. So, in terms of skills needed for driving, and this is not just in our patients, this is in the younger population, this is everybody, we need to have quick reaction times. We need to be able to divide our attention, have good judgment. We need to be able to remember those road rules. Navigation is important, and of course, eyesight and hearing. Next slide. So, next question. Does a diagnosis of dementia mean you have to stop driving? And this one's a bit less options, basically yes, no. Not necessarily, or you're not sure. Good, excellent. Absolutely, not necessarily. So 75% of patients with early dementia may still be safe to drive. It doesn't mean that you're going to be denied insurance. Now, when you move on to a moderate to severe dementia, that absolutely is a contraindication to driving. And we'll talk about what that means. In those patients who you have said, okay, they're okay driving for now, you are going to want to reassess it with their cognition, either every 6 or every 12 months, depending on how rapidly their cognition is changing. Next slide. Some red flags you might hear about from their family members or even the patient themselves. It could be that they have slow response times. They now have traffic violations, tickets, which that they would never normally get. So not somebody who's always got one speeding ticket per year and continues. They're taking too long to get somewhere, or they're actually getting lost. It may be they're driving too slow for the conditions, or on the other side, too fast. Driving through stop signs and red lights, and there are patients with cognitive issues who will actually inappropriately slow down or even stop at green lights. Then there's those things that everybody finds difficult. Merging, those risky left-hand turns. Are they making mistakes there? Have there been any actual accidents or near misses? And then, of course, reports that people are beeping at them when they're out on the road. Next slide. So this here is a nice, really quick 10-minute test that you can do in your office to see what you think about somebody's driving. The first thing is just, do they have dementia? And if they do, what kind of dementia? Because things like Lewy body dementia, they may be specific fluctuations. And so good days and bad days, some days they're okay driving, some days they're not. Frontotemporal dementia, they may not have big memory issues, but they have judgment issues, and that can really impact driving and safety on the road. Now the function, and these are hard and fast rules. If somebody has a moderate to severe dementia, they have dropped 2 instrumental activities of daily living, or 1 basic activity of daily living, which just makes sense due to cognition, of course, not that somebody needs a bath assist due to their mobility. But if they have dropped any of those due to cognition, then they absolutely should not be driving. And that is one of the questions on the licensing form. You want to find out what the family thinks about them driving. Sometimes you might want to do this separately if they aren't really able to speak freely in front of the patient. It's also important and more ideal if it is from a family member who has been recently a passenger in the car with the patient. If they haven't been, and I, at the end of the appointment, do think they may still be safe to drive, I will ask them to monitor their driving once a month. The other thing it's important is not somebody who is reliant on the patient for transport. So, a wife of a husband with cognitive impairment, but she's a non-driver. And so, him losing the license means they're going to be looking at other options. And just kind of asking all those things that we talked about in terms of the red flags. Another really nice question I like to ask is, are they allowed to drive the grandkids? And we do know from research that any restriction in driving, whether it be not driving at night, not driving in certain conditions, not driving the grandkids, but still continuing to drive otherwise, actually is a big red flag. Then there's the visuospatial issues, and these can be tested on cognitive testing. There's the pentagons on the mini mental, there's the clock drawing test, there's the cube on the MoCA. Of course, we also want to look at physical limitations, particularly things like, can they shoulder check, can they turn their head? And that of course goes into things like vision. There are also any medications, particularly if they're causing cognitive impairment, a delirium, drowsiness. We want to look at what medications our patients are on. And then it comes to some testing. There is something called the Trails A and the Trails B that you might have heard of. There's no paper test that's ever truly going to tell us whether somebody can drive or not. The Trails A is they have to join a sequence of numbers, and they have to be able to do it within 2 minutes with less than 2 mistakes. The Trails B is a bit more complicated because they have to sequence numbers and letters, and they have to be able to do it within 3 minutes with less than 3 mistakes. There is also something called the ruler drop reaction, really, really quick to do. You drop the ruler in front of the patient and just basically testing reaction time. Are they able to catch it? And then lastly, judgment and insight. So this is a really nice 10-minute assessment. Next slide. If we go to what the College of Family Physicians recommends, now this is at the care of the elderly level, but of course it is important to any physician dealing with driving in their patients. And so it's important to be proactive. Think about the health-related driving risks and have an early discussion with patients about, what of their health conditions may in the near future impact their driving. Of course, look for any remedial factors, anything we can do to ensure that they stay on the road safely longer. Looking for that corroborating information, so that family report of how they're driving. If it is time to actually give up driving, of course, we want to be patient-centered. We want to make sure we are giving them some alternative strategies for how to manage their transport. And we want to communicate this with both the patient and their family. And this is important because, of course, the patients we're dealing with often have cognitive issues. They may be in denial. Families are instrumental because we know easily about 1/3 of patients will continue to drive, even though they have been asked not to and have had driver fitness withdraw their license. And so we really are dependent on families to be taking away things like the keys or even getting rid of the car altogether. Next slide. This one here is the CMA Driver's Guide, 10th edition. It's a very detailed assessment going through all different conditions, but particularly with regards to dementia, it's reiterating what we just talked about in that 10-minute assessment. Basically looking at that function in terms of basic activities of daily living and those instrumental activities of daily living. And if they have dropped just one basic activity or 2 or more of those instrumental activities, and again, focus on the word dropped. People may often not do a certain instrumental activity of daily living. It may be the wife always did the cooking and cleaning, the husband always did the finances. They have not dropped those, they just never did them. And so it can, take a little while to drill into why somebody's not doing something to determine whether you feel they've actually dropped it. Next slide, please. So who actually decides whether somebody should drive or not? Well, driving is a privilege. And we are very instrumental, but we are not making the final decision. We report our findings to driver fitness and monitoring, and it is them who will actually decide if a patient can still drive and what, if any, further tests they might like. Now, it is non-mandatory reporting here in Alberta. However, I always say it's ethical that we should report patients that we feel are unsafe. And so certainly in my practice, if I see a patient and I don't think they should be driving, I will tell the patient, I will tell their family members, and I will send in a letter to driver fitness. And those last 2 we already talked about. Next slide, please. So in terms of road tests, there are different ways that you can assess your patient's driving, and basically any red flag. So whether it's to do with their visual spatial testing, the family report, when you look at everything all as a whole and you can't make the decision they're safe to drive, nope, I'm telling them they shouldn't be driving. It's those grey ones in between is who I am going to send out on the road for a road test. You can use the Alberta Registry or the Alberta Motoring Association, just like somebody age 16 might do a test. However, they are really concentrating on the rules of the road as opposed to looking for cognitive decline and issues driving that the patients we're dealing with experience. There is also out of the Glenrose, the Driver Evaluation and Training Service. And they will assess the patient. They'll make adaptations to the car if needed, because often they're focusing on patients with physical deficits like post-stroke. Then there's Drive Able. And their big focus, of course, is on those patients with cognitive issues. The Alberta Motoring Association also does have something called a Seniors Driving Refresher or training. And they will do an in-car evaluation, a 2-hour course, and then a 45-minute in-car. And they will then make recommendations for the patient in terms of how to improve their driving. So particularly, let's say somebody's had a big break from driving due to an illness and are now returning to driving. This can be really helpful, but it's not an actual road test. Next slide. So Drive Able, a lot of people don't like Drive Able. However, it is the only test where they are specifically looking for cognitive issues. It is expensive. It's $550. However, generally speaking, if somebody is driving a car, they are paying $10,000 per year, whether it's maintenance to their car, insurance, gas. And so when you put it in that context, this is a small cost to continue to have that freedom to be able to go where they want, when they want, as opposed to using other alternative transports. So it is a two-part test. The first part is a computer-based test, and lots of my patients are like, no, 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 they can't use computers. They don't have to. It's reaction time. They're touching a screen to test that, divided attention, and it will give a percentage about whether they think if they were taken on the road, they will fail or not fail the road test. And they take pretty much all of them out unless they do really badly on it. And of course, they're then a danger to the instructor, as well as anybody else who's out there on the road. The second part is the on-road test. And they will give a list of violations and then make a decision on whether they recommend the patient should continue to drive or not. They also will recommend when it should be reassessed. Usually it's going to be a year. Memory changes are usually quite gradual, but in a patient who has a more rapidly progressive dementia, I would always recommend doing it sooner. Next slide. So times when people do have to stop. That moderate to severe dementia we've talked about, it could be a vision problem because there are cutoffs for the minimal amount on the road form about vision. It could be hearing, but that's usually the higher classes of licenses, not a class 5. It could be musculoskeletal if they can't shoulder check. And then there's lots of temporary conditions whereby patients may regain their license at a later date. And so that can be something like psychosis, syncope, seizures. It can even be sleep disorders. I've seen people lose their license with sleep apnea, and then as they are on CPAP and they have less episodes, they regain their license. After a heart attack or a stroke, if people have arrhythmias until they're under control, delirium, or a traumatic brain injury. Next slide. So I mentioned that, while it's not mandatory, I feel it's ethical. And I have two different letters that I send. One is when I just feel they should stop driving. And then the other one is whereby that gray area that we talked about. So I feel they need a road test. And so my letter this time says no driving unless they pass. And I do prefer drive able. Next slide. And
Okay, thank you.
back.
Yeah, thank you so much, Lesley, for that. So we'll go back to Mrs. Forgetful. She's now 6 years in. She's still living alone. She has full ADLs, and as we discussed last week, those are the basic activities of daily living. Her daughter is managing her finances, and she's now no longer driving. Her MOCA is now 15 out of 30. And her daughter is concerned about her mom being more anxious and struggling with her own hygiene. And she is not does not often shower. So how would you categorize her dementia now? Mild, moderate, severe, or end stage? Whoops. So yes, most people said moderate, and I agree. She had like more than two IDLs. She's got a little bit of behavior problems. Her MOCA is sort of in that range. It all is in keeping with moderate dementia. What are some low-hanging fruit in dementia care? I always look at sleep. A favorite of mine is magnesium bisglycinate. Everyone should be on it. Melatonin if they have Lewy body dementia, and then trazodone I find can be quite helpful. It's not supposed to interrupt the REM sleep cycle. I don't know how true that is. I think listen for safety issues like, are they leaving the stove on? Are they wandering and getting lost? You can get a tracking device for that. I make sure that they don't have chronic pain, so things like scheduled Tylenol long acting. I do like Voltaren gel for like smaller muscle joints or just muscular pain that they get on top of their arthritic pain. And also if they're sort of older or maybe they're getting a joint replacement, I will often suggest steroid injections to bridge the joint replacement. Very, very important to ask about constipation. I use PEG as well as Senna. And as you will hear from our Parkinson's disease expert next week, we need both the mush and the push, is what she always teaches the learners. For weight loss, I love mirtazapine. It really works quite like a miracle almost. There's not many people who it hasn't worked for. And what's nice about mirtazapine, it also can be used as sleeping aid at night. Caregiver burden, you got to ask about it, and you can see if there's anything that home care can come in for. And then, of course, make sure that they've thought about or have a personal directive and power of attorney. And this is really important, as you will see in the last talk, just to avoid those court-appointed decisions. Whoops. So on further questioning with Mrs. Forgotful, she feels very anxious. She's more anxious. She has trouble sleeping at night, especially falling asleep, and she has lost about 10 pounds in the last year. So what would be one of your things that you would do? Mirtazapine, sertraline, examine the teeth for any dental caries or poor feet or poor fitting dentures. Make sure she's having daily bowel movements. Consider doing a flat plate of the abdomen or A, C, and D. Oh, everyone is amazing. Yes. So the drug of choice would be mirtazapine, just because she's not sleeping well, and also it may help a little bit with her anxiety. At the 15 milligrams, it's not like a great level of antidepressant, but it will help with appetite. Um, and then whenever people lose weight, always make sure you look at their teeth, even if they can have, like, if they don't complain about having very painful, I would send them for just like a Panorex to make sure they don't have any small underlying abscesses, which can really affect their eating, poor fitting dentures. And yes, as you know, you guys are all family practice. Constipation is almost like an epidemic, and it really has all kinds of effects on the elderly too with their appetite. Now, when we get into BPSD, this is a very, very old, from a very old study, but I just love it because this is the way I think about the BPSD symptoms or what's going on with them. I like to think of them like, what kind of cluster are they falling in? Are they sort of aggressive? Are they agitated? Are they more psychosis or mania? Or is it more like apathy and depression? And, BPSD, like a lot of these symptoms are very, very common. At least they say 90% of patients with Alzheimer's dementia will have like agitation. You can just see the list of them. And these symptoms actually present before the cognitive symptoms: apathy, irritability, depression, agitation, anxiety, sleep disturbance. So psychosis is more frequent in the moderate stage and disinhibition in earlier stages. And hallucinations, of course, happen more in Lewy body dementia. So it's important, these are the non-pharmacological ways. Look for the stressor, right? And think of ideas that you may be able to help these people: massage, music, art, exercise. Identify triggers like alcohol, traveling, busy parties, what the patient can still do, chores, help with setup. Repetitive motion exercises are very soothing. I had this one case many, many years ago where the husband, he liked to paint, and he would just had this big old suitcase of photographs, and he would have his wife sit beside him. And because in there, when the dementia advances, they can have a lot of memories still present from long ago. She would pick up a photo and describe it, and it just brought her a lot of joy. Um, Allow the patient extra time to respond when you're talking to them. Lots of cueing, very short commands, like not multitask commands. Identifying yourself and others if the patient can't recall. And also having a safe environment, reduce clutter and noise, structure daily routines, optimize the sleep. And this is, I always do a little kind of like educating the caregiver attitude. Like, don't try to get into arguments. Recognize that it's the disease and not the progression and not the person. The behaviors aren't intentional, and you have to sort of have this attitude that you're living in their world now. And the progressive disease means constantly adapting and changing the expectations. And I saw this firsthand when I was training, in Boston. The families that did really well, they would come in for follow-up and they'd go, okay, well, we can no longer go to the coffee shop because this incident happened, but now we're just staying at home and I rigged up the TV remote. They only have to press one button now. The phone is set up. There's only one. And I often say that to, like to patients and family too, like if all of these symptoms, if this was a cancer and they were like, had something like they lost their bowel control, then you wouldn't be mad at it. And it's just really, really hard with dementia because the symptoms it's not an overnight thing. It happens so gradually and it's just frustrating for the caregiver. I wanted to give some pearls about psychotropic drugs. Avoid high anticholinergic loads like the TCAs. Paxil is just a bad culprit, olanzapine. Having said that, do not stop or like get too aggressive about stopping Paxil because it is something else. Minimize the number of psychotropic drugs. For example, you can give trazodone in lower doses in the daytime. I often will sometimes like add it on almost like a benzodiazepine in the daytime and then a bigger dose at night for sleep. Choose drugs that help multiple symptoms, and that's our mirtazapine. Start very low and go slow and revise. Um, and after 3 months, when you've stabilized, just see if you can drop the dose a little bit. I often find family will be very resistant, and you can just tell them, hey, we're trying to reduce it. Let's look again and try again in 3 months. If you don't have an effect after 6 weeks, then just try a different drug. I always have this line, and you guys know it best, but it's kind of like birth control pill, right? What works for one person or one lady, I should say, may not work for others. So it's trial and error. So in neuropsychiatric disorders, there is kind of a rule, like things I go by. If it's Lewy body dementia, acetylcholinesterase are your first line. And if they can't have that, because we talked last week about they have a very low heart rate or they have more than a second degree, like a left bundle branch block, then you can also try memantine or Ibixa. But people will have to pay out of pocket about $100. SSRIs, citalopram and sertraline are good old geriatric standbys. I know a lot of family doctors prefer using escitalopram, and that's okay too. For the atypical antipsychotics, you should try to avoid it, but solid indications are if they're just very agitated, such that they're resistant to care or they're really stressing somebody else out, and if they have visual hallucinations that are distressing. Risperidone and aripiprazole have the most efficacy in trials. And this was kind of an interesting bit. Seroquel is actually the least useful because it's the least DA blocking, but it has its place sometimes. If it works for someone, then I wouldn't take it off. And actually, for Lewy body dementia and Parkinson's disease dementia, Seroquel is really your only choice. Dose accordingly if there's sundowning. One helpful tip I learned in my fellowship, and it's really makes a big difference. If there's sundowning, try to find out when that time is and give that, atypical antipsychotic about 2 hours before the symptoms start. And always try to reduce antipsychotics, as we said previously, because they are associated with increased falls and actually decreasing the cognition. So depression, you can diagnose with a 9-item PHQ. You can simply just ask family, like, do you think they're depressed? And we talked about the SSRIs of choice. SNRIs are much more activating, I find, but if they also have chronic pain, I like duloxetine and we can give it a try. And I prefer it over Effexor because, as you know, Effexor will often raise the blood pressure. You can use these antidepressants in combination with mirtazapine at night. And mirtazapine may actually, I think of it more as an augmenter to the other antidepressants. I don't give or prescribe a lot of bupropion, not at all. And often when I find in hospital, when I get consulted and people are really agitated, that'll be one of the first things I decrease because I think, I won't like cut it, of course, like totally, but if you just decrease the dose, because it can be really quite activating. In apathy, again, stimulants such as methylphenidate have been shown to help. Modafinil is inconclusive, the studies on that. I don't prescribe a lot. I wish I did, so I had more experience, but I just don't. But I think it's worth a try if they're really, really apathetic. But just remember to go very low and monitor their weight and see if they're still sleeping okay. I think sleep and appetite trump, how chipper you are in the day. And in Lewy body dementia, acetylcholinesterase inhibitors are again very useful for apathy. Now, I want to talk a little bit about Abixa because it's really marketed for moderate to severe dementia. Its glutamate, as you know, goes in through the N-methyl-D NMDA receptor, and that causes an influx of calcium, which is both excitatory and neurotoxic to nerve cells. Now, as you can see, memantine down here, you can see the little unhappy nerve cell. Memantine doesn't block the receptor completely, but it kind of is almost like a partial door stopper. So it kind of decreases the amount of calcium influx. And it's recommended in moderate to severe dementia, and it can treat, again, a little bit of the cognition, but I find more of the behavioral symptoms. We start like at 5 milligrams once daily, then ramp it up to 5 BID, and you can go as high as 10 BID. It can be sedating, it can cause confusions, headaches, and constipation. And its relative contraindication is in renal failure, so a GFR less than 30 or severe liver disease. In the States, it's always piggybacked with acetylcholinesterase inhibitor, but in Canada, we still don't have coverage, but it's only about $100 a month. And so sometimes, like, especially when they have really, really bad behaviors, it's kind of like a Hail Mary and family will be happy to pay it, especially like say if their loved one, if the life expectancy isn't that much longer. And so the general treatment recommendation, I wrote them in here again, is SSRIs, avoid Paxil unless they're already on it. For the psychosis, make sure you're treating the sleep. Atypical antipsychotics, identify the timing, like sundowning, and then SSRIs, avoid Paxil. And you can also treat with sedating antipsychotics like Seroquel, Trazodone, acetylcholinesterase, or memantine are all options. And the one I didn't write in there, and we will get into it next week. If it's frontotemporal lobar dementia, we don't want to give acetylcholinesterase inhibitor. So kind of my general summary of how I treat BPSD. So I make sure sleep and constipation are addressed. And I also address, like, I don't want to stop things like benzos or Imovane suddenly because these can cause withdrawal symptoms. And then generally we go for an SSRI, and the trazodone can sometimes be used to augment behaviors, much like a benzo. And then, if needed, mood enhancers, and in Aricept, rivastigmine. And you see the little star there. Never use acetylcholinesterase in FTD, but in Lewy body dementia, I would probably prioritize the mood enhancer like acetylcholinesterase inhibitor. The antipsychotic, rivastigmine is the most effective. And, if at home, if they're doing PRNs, I find Zydis, which is an olanzapine wafer, is quite helpful. And I use it if they have hallucinations or they're very agitated. So let's go back to Mrs. Forgetful. She's now 7 years in. She's regained 10 pounds. She's sleeping better. She's still anxious and she's starting to question her daughter if her daughter is stealing her money. She's forgetting to take her the pop quiz always pops up, right? Some of her other meds, even though they're blister packed. So what would the next step be? Would you add sertraline, start risperidone, home care referral for needs assessment, all of the above, or A and C? Okay, and what do you guys think? Yes, so 66% A and C, and that was kind of what I was hoping for. A lot of people, a couple of people wanted to start risperidone right away. There's no extremely right answers, and you wouldn't be, uh, you know, faulted for it. I try to wait a little bit longer. Now, if she was having symptoms every single day, I would probably start her on sertraline and give them a PRN risperidone or try like a very small dose of lower risperidone and make sure I follow up again within a month to see if it's helping or not. So home care referrals, what can they actually offer? So they're great for giving baths, for dressing people and undressing them so AM, PM care, we call that. And also they help with personal hygiene. They do not, toileting and transferring, they can help transfer a person up, say, into the wheelchair, but they're just not there all day long. So if a person wants to get up and walk or whatever, toileting is really the big one because it's like almost like a as needed, and home care just isn't there as needed. And as we said, feeding, no, but they will sometimes feed and even cook meals a little bit if the person has visual impairment. They don't do finances, transportation. Hopefully, a person's not driving, but also they give medications up to 4 times a day, and they can give insulin as well. But they do not do PEG, not PEG, sorry, the GI feedings. They don't do that. We expect family to do that. And again, with meals, they will help with cooking for people who are visually impaired. So you can see basically shopping and housework. Home care does not do social home care, which is, I think a lot of elderly would feel they would want that. They can also arrange for respite care. So 1 to 2 times a week, 2 to 3 hours a week. You can ask people, home care will handle the referring to a day program, which I find very, very helpful. Um, and they can also do environmental hazard checks. So that's done by their OT. So the way to think of home care, it's not just like, the home care nurses that come in, but they kind of have like this whole little team. And at the very top, they have like sort of a manager who may do the, like, if things get difficult and do a higher, like a needs assessment. They have an occupational therapist. And what's recently happened is in home care, we have something what's called invoicing, and I got it actually mixed up with self-managed care. And I was talking to one of my transition coordinators in the hospital, and she says self-managed care is mostly replaced by invoicing. So this is something where you can talk to the patients about, but then again, home care would come in and then home care would provide more information. But they basically assess the person and they decide how many hours that person needs. And then they give the client, the family, sort of a bunch of like just designated private care options. And then the family can choose who they hire, how many hours a day they want, and then AHS manages the payment. And I've seen as much as 38 hours a week. So if you think about that, that's almost like 7, 8 hours a day if you go Monday to Friday, or 6 hours a day if you go like 5 days a week. I'm actually shocked, to be quite honest. And I think for a lot of people, it's a really good way to go. And then often what I find is family will say, well, they can have a constant care like person there, right? The patient, if the family opts into this, you can no longer go to services like home care services like the day program, because that would be considered double dipping. Ask about caregiver burnout. Always, always just ask. It makes such a difference just to talk to people and tell them that they're doing the best they can and that this isn't easy what they're doing. And I think a lot of like caregivers, as well as the clients, they don't really know when it'll be time for a patient to be institutionalized. And so for them, they either want their loved ones institutionalized right away, or they fear, like they go, well, when is it going to happen? We talked about respite care, that like just a couple of hours, a couple of times a week, so the person can go out. The day program is nice because then they'll be gone like for 5 or 6 hours twice a week. And sometimes, if the family really just wants to go on a holiday, there are some long-term care and supportive living that offer like week-long stays for um, patients while the family is gone. And I would also recommend like the Alzheimer First Link for group support and education. The Glenrose also does like a monthly Alzheimer's like education program. And some caregivers just really aren't into it and some really like it. So we'll try to get you those links as well. This is a slide I got when I was a fellow. And sometimes like people just want to know like when exactly. And I kind of try to like say this is the trajectory, right, of dementia. At first they lose their driving and then they get more, you can see the older terms being used here that we used to do to diagnose, but they still hold up. But people usually get institutionalized when they're incontinent, or they need constant cueing. And at the very end stages, they're like bedbound and mute, and they have no memory at all. So let's go back to Mrs. Forgetful. She's now 8 years in. Her MOCA is 7 out of 30. She really slid in the last year. She gets home care BID. She goes to a day program twice a week. She has difficulty with walking, and she's often refusing home care to come in at all. Family is now bringing in, doing all the IADLs, including bringing in food, and shopping and the housework. What are the triggers that, again, that pop quiz, that that a person needs to have higher level of care when the family wants them to, unsafe behaviors like wandering, needs round the clock queuing, fecal incontinence, and then B, C, and D. Okay, let's see. Oh, you guys are brilliant. Yes. So all of those, like fecal incontinence is a funny one. I had like one patient who happened to they were fecally incontinent, but they happened to just go when home care was there, so it worked out. It's kind of like babies. Like you can pee gets absorbed into the diaper, but the fecal matter just eats the skin so quickly. It's really unethical to let people like sit like that at home, right? Wandering, it really depends how unsafe it is, and if it, like, I told you, or I will tell you guys about a little lady who wandered a couple of times, knocked on some doors, but then found her way back to someone who wanders across the street in construction or in the middle of January. And when family wants them to know, that is not true, right? So you have to reassure family that you have to have a trigger for them to, and, meet the requirements. And unfortunately, in our healthcare, it's very much um, based on function, unless, of course, it's private, and then it's much different. And And so I had like maybe one case. I'm thinking of the strangest cases, but one was that a gentleman was living on his own and he had needed to go to the hospital. He was lying on the floor, but he wouldn't go with an ambulance. And even though he was living at home, he refused to go in the ambulance. And I said, okay, sure. And they wanted to have the sort of just that, they wanted to know that their loved one would be able to get on an ambulance the next time this happens. Um, so the take-home message, driving cessation should be considered for moderate and onwards dementia. In mild dementia, patients can drive, but they should undergo frequent on-road driving tests. DriveAble is better at detecting cognitive limitations to drive safely, and the on-road driving test through the Ministry of Transportation is better at detecting the functional abilities of driving. BPSD of dementia can occur early before dementia and should be treated, and SSRIs are really usually the mainstay. And antipsychotic use should be considered if refractory BPSD, like, really very angry or like very agitated, sundowning, or visual hallucinations. And they should be attempted to taper it every 12 weeks. And here are some references. And I'll stop sharing. Is that what you want me to do?
Wow, wonderful. Thank you. We have a number of questions um, for the panelists. So the first question we have is, would you be able to share your reference materials for the magnesium recommendation?
Like an actual study? I it hasn't been there, there are studies now showing like headaches and restless leg syndrome, and I just like it because I feel like it's an augmenter, but it has to be magnesium bisglycinate, and I go upward of about 400 milligrams, and I just prescribe it. I take it myself. It works so well. And it just is very relaxing. And my patients will often say, oh, I used to have like a jittery heart and that's gone now. But, on its own, I don't think it's much of a sleeping aid, but I will certainly, when we put out the whatever we do with references, I will try to add that. Lesley, anything that you want to add?
No, not for that magnesium, no.
Yeah. If it's not the bisglycinate, like the oxide or the citrate, it can give you loose bowels, and that can be not such a good thing because you'll wake up having to run to the bathroom.
The next question is, do you recommend people start B12, vitamin B12?
Not routinely, but I don't think it can hurt, just as long as you're not overdoing it. And there is some, I am a podcast listener. Do I have vitamin B12 on my counter? Yes, I do. Do I take it every day? No. But there is some idea that, it can maybe help, but the evidence just isn't really there.
There's a question on, why is memantine still not covered by Alberta Seniors Blue Cross?
I wish I had an answer. Alberta Blue Cross is very silly sometimes. Lesley, I
Well,
think
I
maybe
think,
if we,
the decision was made a long time ago that they felt that there wasn't enough benefit to cover it financially. And I guess it's never been appealed, and I guess it will never will be at this point, because, I mean, it's been around easily for 20 years.
yeah,
Going back to that B12, we do sometimes check B12 levels in patients, or sometimes they've just had them done anyway when they come to us about cognition. And we do normally like to see it a bit higher than the actual lab cutoffs, which
yes,
is 150. I personally go with 200. I know some people go with 250. And so in those patients, you definitely want to consider replacing the B12.
yes. And I totally agree with that. I think, and that's our practice as well here. And some of my colleagues like to have it even over 300.
Mhm.
Um, so yes, definitely check the B12 and replace, and maybe aim for a little bit higher than what the tab lab test cutoff is. Yes.
The next question is, my patients are asking about genetic testing for early diagnosis. They don't have symptoms. They would like to try new medication to prevent. Any thoughts?
Yeah,
So,
I'll let Lesley just say it. Yes.
sure. So number one, the genetic testing is not for early diagnosis. It's purely to see if they have the ApoE allele, which is a contraindication to treatment. The other thing is that it's only indicated in mild cognitive impairment and early dementia due to Alzheimer's. So if they don't have any symptoms, there's no treatment for them at the moment.
Yeah. And so part of it too is like a lot of us will have like one allele, like we'll have one, because you can have two, right? One on each allele. And if you have one, it doesn't necessarily mean you have dementia. So you may find it, but you may not have dementia. So it's unnecessarily stressful, right? And a lot of people will have dementia and maybe not even have that ApoE allele. It's just that if you have two, the reason we screen for it for the new medication is that you're more likely to have more amyloid and you're more likely to be at a higher risk of having potential bleeding side effects. But it's not really indicated right now to screen. It's not going to be helpful for screening for dementia. Do you agree with that, Lesley?
Oh, absolutely, because it's only identifying a risk. The only people we'll be doing genetic testing on are those who we are considering for treatment.
Thank you. Is memantine recommended if patient is already confused, if it will cause more confusion?
It's always worth a try. Like it's so hard to like to kind of figure out like, is this delirium? You can, it's just one of those things you can sometimes try it. For me, I only ever really offer it, say if people are really like like have almost like a very agitated anger about them. I don't know what I don't really in moderate dementia, I don't really prescribe it to improve cognition. What about you, Lesley?
So I will give it a try. Like when people have progressed on cholinesterase inhibitor, I might give it as a try to add in to see if we can get a bit more period of stability.
Yeah.
And it does sometimes, but of course, dementia is such a gradually progressive disease. Sometimes it may just be that we're capturing that. I will also use it when I have at times used it when people are agitated. Because, of course, not many people do get more confused on it. That's just a small number in terms of side effects. And yeah, with anything, it's always a trial, seeing how they
Yeah.
do on it or whether they get worse.
Yeah. And I find it's sort of interesting, Lesley. I love hearing how my colleagues practice. I think because, like, you would be surprised, but for me, like, for my clientele, and like, people often don't want to be on more drugs. They can't afford it. So it kind of just waters down the population, but I probably should be offering it to more people and asking. But just because so often people don't want to be on more drugs and have to pay for it. So anyways, yes.
Absolutely.
Um, you mentioned PHQ-9. Is it worth to do the GAD-7?
To determine depression, yeah, it definitely is worth doing. We often do the geriatric depression screen in our clinics, which is a little bit, again, it's like, it's actually, I don't think it's actually it never really got proven in dementia. But I think to be quite
There's
often,
a clarification
oh,
around
sorry.
anxiety. Sorry.
Oh, for anxiety. Um, I'm going to let Lesley speak to that one. I don't use the tests as a high. I don't use them a lot. I just go by what family tell me. If they tell me they're a lot more anxious, and then when I see them and talk to the patient, and also my nurses are really good at saying, "Oh, they seemed really on edge and anxious," but I don't rely solely on the tests to diagnose anxiety. What about you, Lesley?
Absolutely. Like I don't do a specific test like the GAD just because we already are doing other multiple tests, whether it be RUDAS, sometimes a second cognitive test, the GDS. In terms of depression, it is the GDS and the PHQ-9 that are indicated by the Canadian Coalition on Seniors Mental Health. That's the two that they recommend. But yes, definitely with anxiety, just with time limitations, it is more just a history. And whichever one of them it is, whether it's cognition, whether it's depression, it's always looking at things in terms of the history domains, function, neurobehavior, and testing, because they don't always correlate. And so we can't just go by a number.
Thank you so much. Well, that brings us to 1 o'clock. So thank you so much, everyone, for joining and for all the great questions. There are a few questions that remained unanswered, but we can take a look and see how that might relate to the Pearls for Practice that will follow, that will be sent to everybody who's registered. So really appreciate you joining and sharing your expertise with us today. And I wish everybody has a very sunny and wonderful afternoon. So take
Thank you
good
so
care and
much.
see you at
See
the
you
next
next week.
webinar.
The next
Yes.
one will be a doozy.
Thanks. Bye.
Thanks.